And I got these handouts here. This is just a couple of slides that'll give you some background information on the data we collect and how we collect that data. Of course, for our case identification, as I mentioned in the presentation I gave earlier, there's a few different ways that we identify cases. The first is through the ICD-10 codes, the obstetric codes. Those are pretty much how we identify pregnancy, most of our pregnancy-related deaths. We also have the vital records cross-match, which is the cross-matching of the fetal death certificate or fetal birth certificate with the maternal death certificate. And we also have the death certificate checkbox, which previously only went up to 3 months prior to their death, and now it goes to up to 365 days for the pregnancy. And we also identify some cases through the Virginia Violent Death Registry system, which essentially, for those cases, we often find our abortion cases and our miscarriage cases. Those are cases who they may not have had any prenatal care, so whoever was filling out their death certificate may not have had that information, but in their investigation of the death, they found out this person had an abortion 2 or 3 months before they passed, or they had a miscarriage a month before she committed suicide. Those type of issues. We also, in preparation for our case review, we obtained the death certificates and fetal birth certificates or death certificates from the Office of Health Statistics. They provide that to me, the team coordinator, who I then look at those and track the birth attendant or the hospital where they died or the hospital where the birth occurred, and we start there, obtain those records, and then work our way backwards. So really, as far as the accuracy and the amount of records that we get, it really comes down to how well things are documented in those first records that we can get. And we have multiple rounds of record collection, so it can take 3 or 4 times, because every time you get a new record in, you have to go through that record, scan through. Okay, she saw this OB, she saw this cardiologist, let's go get those records. Once we get those records, did she see anybody else? Did they document all of that? So it can take several rounds of record collection before we have all the information we need to create our case summary. Some of the records that we do receive include Child Protective Services, hospital and emergency room records. We also collect labor and delivery, law enforcement records. Very rarely are we able to get jail records. There's nothing preventing us from getting that. It's just a question of, do they want to give it to us? So every so often we can get records from jails if they had birth in jail within the 5 years prior to their death. We also get medical examiner records, which includes autopsy, any toxicological pathology findings. We also look at their circumstances, the medical investigator death review investigation. We get that information as well. We look at any mental health records from CSVs, as well as any treatment programs that they were in, any private psychiatrists or therapists that they went to see, we try to get those. We also look at the prenatal care, primary health care, any social services records, or any substance abuse treatment. And there are several ways that we could have potential data inaccuracies. The first of that would be the inability to obtain pertinent records. Like I said before, our record collection really is only as thorough as the information that's in the first records we can get. So if we don't have, specific providers to follow up with or to search for records, we don't have that. In certain places or certain women, they grew up, if they were in a rural area where there are only so many providers in their area, at times we can do what we call fishing expeditions just to see if that woman was seen by those providers. But in a place like Richmond, that's not something we would be able to do here. There are way too many providers, too many potential avenues of where they could have gone for treatment. So that wouldn't work here, but in our more rural areas where there are a limited number of providers, that's another potential way that we could find a place where they received care. Another potential source of data inaccuracy would be missing information in the medical records. Sometimes you have an abundance of information, sometimes you have very little information. What we found now, though, is with the electronic medical records, we're starting to get banker boxes of information. So you're wading through 1,000, 1,500 pages worth of records just to see they went and saw a prenatal care provider. This is who that name is. So sometimes you have an abundance and overwhelming amount of information, and other times you just don't have the information that you need documented in those records. And that can vary from facility to facility. It can vary from patient to patient within a facility, from, depends on how each individual provider document their care. All of that's going to determine how accurate and how much information you're going to actually have in your medical records. And we also have problems at times with the illegible information on the medical records. If you ever try to read most physicians' handwritings, it's kind of okay, this might be a while. This looks like it could be LASIX. I don't know what that is for sure, but that's a problem we have. That's somewhat been remedied with these electronic medical records, but not all facilities are using electronic records even in 2019. So as more of them cross over to using those records, illegible notes will become less of an issue. There's also at times conflicting information between records and within records. And a lot of times that could reflect questions that are asked by providers. Sometimes you'll have a provider ask a patient a question one way, and they may not get a full answer, but someone else asked them something different, so you see at another visit that their answer is totally different. You can also have differences in information between providers. She may tell her OB that she's had a history of substance abuse, but if she goes to see her primary care doctor, she's not telling him anything because he's giving her the pain medicine. Things like that. So you have differences in what women are telling individual providers, and so you kind of have to document what you have in each of the records, and if you have conflicts, actually note that. So then instead of maybe trying to pick and choose what would be correct, you're actually looking and seeing, able to say, okay, there was a conflict between this visit and on this visit. We don't know which one it is, but later on down the line, the more she saw other providers, the more we figured out that, okay, it was X, Y, Z. So, once we get all the data that we are able to get, we then prepare the case summaries and present it to the team for a case review. And as we mentioned before, the 3 primary questions that we ask is, was the death pregnancy related, was it preventable, and what factors contributed to the death? What changes could have been made to prevent the death? And all of this information we use and we document and keep it in the maternal mortality database. Currently, we're using an older version from the CDC, the Maternal Mortality Review Database System. They're currently working on the new MARIA system, which is the Maternal Mortality Review Information App. And they're pushing that app to be used by maternal mortality review teams throughout the country, which will give us all the same database with data that looks similar that we can actually then start to compare to each other. And with having that one database, we can have guidelines and start working on definitions so that there's more consistency throughout the country, and then we can actually start comparing to see, okay, where are we in terms of the nation? Where are we in terms of our neighbors? And that way we can look at, okay, what are you guys doing to improve these numbers, and kind of be able to share information that'll actually be relevant to the work and the data that we have here. So as they're working on that now, and they're hoping to have that centrally hosted within the year, so we'll be transitioning to that new CDC database, hopefully within the next year.
Do lawyers ever subpoena some of those?
That's a good question. We actually, our meetings are non-discoverable. And that's part of why we wait past a certain point. We have to make sure that all of our cases have been settled. If there's anything legal happening, particularly for homicides, those type of cases. So we have to make sure that those are all, prosecuted and everything is settled before we are able to review that. But nothing that occurs in our meetings is discoverable.
Is there a release that someone signs for you to obtain the records? Are you able to retain them? Able to obtain those records?
We actually used the Health Commissioner statute to collect records in the interest of public health significance. And so that's the statute that we send out when we send out our record request to say, hey, we've been mandated to do this, collect this data and this information. Here's a statute. And because we've actually been able to have a good relationship with a lot of people, and as a team have a good reputation throughout the state, we haven't really had any issues in being able to obtain records.
Did you get this statement with the jails may not get you may not get that?
Right.
They don't have to give you
they don't have to. We try to get those records if we can. At times they've been generous enough to give it to us, but they don't necessarily have to give us those records.
With that centralized app that you're talking about, will any data be loaded retrospectively, or is it just going to be starting fresh and moving forward?
It more than likely will be retrospective. They have some states that are using it now, it's just not centrally hosted, so each state is hosting their own, and we're waiting specifically to wait until they have centrally hosted.
So with the advent of the electronic record, will it be to where like you could be like Big Brother looking in on doing with the electronic chart per patient identification versus getting all, I can't imagine going through all that paper. So do you think with it, if we have a patient identifier, like for the military, for example, we now can look at our reservist wherever they go. So it used to be, if we didn't even know if they went out on the outside, as far as care goes, we didn't know who they were seeing. Now we know what they're seeing, what they're doing, and we're finding out that there's a lot of things going on with our reservists that we weren't aware of, and it affects the readiness of the force per se. But it's because we can go in and see that. So do you think it'll get better if you could have an overall big bubble picture?
I think that there's a way that we can use that to help. I don't think we're there yet. And it definitely would take some work to kind of figure out how best to make that happen. But with the electronic records, that definitely opens up that possibility.
And you all don't look at the RCA, you can't look at the RCA piece of it.
Right.
Okay.
Yeah, Meagan discussed the
So I'm Meagan Robinson. I'm an MPH Epidemiology Supervisor at BDH within the Office of Family Health Services. I'm located in the Division of Population Health Data. So the purpose of our division is to supply all the population-based data to the other programs within the Office of Family Health Services in order to guide their programs, their decisions, their initiatives, and also for other entities within the state who need population-based data. I'm particularly just over the maternal and child health team, but we also have our population health surveys that are managed within our division. We have the Behavioral Risk Factor Surveillance System, or BARFIS, which looks at all of the health behaviors and other types of behaviors that may affect health within the adults in the state. We also have a Pregnancy Risk Assessment Monitoring System, and Kanisha is the program coordinator for that program. So that looks at maternal behaviors before, during, and after pregnancy. And we have a Youth Risk Behavior Survey, YRBS, which looks at the behaviors of our adolescents within the state. So for the maternal and child health team, we mainly use birth certificates, death certificates, induced termination of pregnancy data, and fetal death data. We also have the early hearing detection initiative. We have an EPI who looks at their information, and we also have an EPI that looks at newborn screening information. So mainly with the vital records data that we use, that information is housed within the Office of Information Management with the health stats team. So when it comes to data quality and use, they have a long, exhaustive list of things that they have to do to prepare their data in order to supply it to CDC and the National Center for Health Statistics. And they have a deadline each year that's set that they have to have the information to the National Center for Health Statistics. So, but they also do their own checks just within Virginia alone for our use of their data to make sure that it's verifiable and useful for us. So they go above and beyond what's due to the National Center for Health Statistics to make sure they verify that data for our use. So sometimes, maybe if some of you have ever used like CDC Wonder or things like that for data use, there's a different cutoff point for submitting data. So sometimes our numbers may be a little bit different than we may report than for CDC Wonder, but that's just because we've taken an extra step forward to go throughout the entire year to verify that data. It's not that it's statistically different, like it may just be 2 or 3 births ops, like this. Other things we have, we also do data requests. I get a lot of data requests from districts and newspapers and things like that for MCH related data. that we can get from the birth certificate. There are over 300 fields within the birth certificate, so there's a lot of information. One of the main things I get asked about is income data, so that's not in the birth certificate, but Kanisha has income data within Perinatal. So I will forward people to her for things regarding socioeconomic status and things like that for maternal childhood data. We also have a data portal that's on the VDH website. On that portal, a lot of questions that we get multiple times, I try to have those indicators posted on that portal regarding the population of women of childbearing age, population of teens, teen birth and pregnancy rates, preterm birth rates, prenatal care initiation, a lot of things like that are available on that portal by year and also by locality, and you can look at it by health district also for Virginia. So we try to get that, have it updated on a regular basis. We try to do a better job of that, but at the same time, that data is housed within the Office of Information Management, and sometimes I'm left up to their timeline of when they're like, okay, man, green light, go ahead, use this data to be verified. And they'll verify, they'll also send it to me to verify, to see if that's what I'm seeing or what I've been seeing consistently over the years and throughout the years. So that's about it. So, have any questions?
I have one. The portal you just spoke of, is that something that's unviewed to the public?
If you go to the VDH website, and there's a tab at the top that says data, and click on data, it'll take you right to our data portal. And so there are a few dashboards on that portal, including opioid addiction portal. There's a portal for population health, for chronic disease. So there are a few different portals available on that page. And if you have specific data